welcome again to the EHealth Initiative webinar on digital health credentials, Behind the Buzz. I am going to learn how to run slides and start with some housekeeping. All of you should be muted should you have questions, and I will do my best to leave some time at the end of the discussion for some Q&A. Please submit them in the Q&A box. If you have technical difficulties, I'm sure they're my fault in some way, please use the chat box for that, or questions, comments unrelated to Q&A on the presentation. We have no formal agenda today other than a discussion, but we do have some fantastic speakers. I'm really honored and grateful for those panelists that have joined us today. I'm going to give them each an opportunity in a few minutes to introduce themselves in more detail, but we have with us today Todd Kerke, who is the Chief Architect at ID 2020 and working affiliation with the Good Health Pass Initiative. Dr. Matthew Harris, who's the physician lead and COVID vaccination COVID vaccination program at Northwell Health. Jerry Koester, who's the Chief Information Officer at the Marshfield Clinic Health System. JP Pollack, the Chief Architect at the Commons Project. And Mark Treshock, the Blockchain Solutions Leader for Healthcare and Life Sciences at IBM. So an illustrious group, as you can see. And then very far down the food chain is yours truly. I'm Alice Leiter. I am a Vice President and Senior Counsel at the EHealth Initiative. The EHealth Initiative is a membership organization. You can see some of our fabulous members here. Our work focuses in three main areas: education, advocacy, and thought leadership. We conduct educational programs, webinars such as these. We advocate for policies that our members and leadership council have aligned behind, largely through our policy steering committee. We also conduct expert roundtables, host advisory boards and work groups, conduct surveys, and convene expert faculty. If you'd like to learn more about us, you should visit our website, where you can also see more related to our current critical issue areas. Right now, we're doing most of our work in consumer privacy for health data, which I'm leading, also in the areas of virtual care, analytics and social determinants of health, and then, like everyone in the world, work around COVID-19 best practices in education. I will not read all of these, but we've had a very busy spring with forums and webinars. You can see some of them here. And again, on our site in the Resource Center, all of these and the materials from them are uploaded and the recordings are available. Also here, you can download some of our recent publications. I'll give a bias plug for the Consumer Privacy Framework for Health Data, but we've had a lot of good work go up there in the past couple of months, and so I urge you all to check it out. None of this would be possible without our sponsor. I want to thank Imprivata, who is a wonderful thought partner on convening this webinar. So much of EHI's work is made possible through our generous sponsors. If you would like to sponsor anything, you can come right to me, and we're very appreciative. I'm going to stop sharing my screen for now because, again, I think this is going to be a good discussion, and it's always nice to see the beautiful faces of those people from whom you're hearing. So again, welcome, and I'll start by asking each of the panelists to introduce themselves and tell us a little bit about your work, your experience with digital health credentials, either historically through your background or now in the COVID era. And I'll go in the order on which I see on my screen, and I'll start, please, with Jerry.
So thank you, Alice. My name is Jerry Koester. I'm the Chief Information Officer for the Marshfield Clinic Health System. And so thank you for having this panel, Alice, and bringing us all together for this conversation. Marshfield Clinic Health System is a rural healthcare organization located in central Wisconsin, close to $3 billion size organization with not only the ambulatory, but the acute care space, as well as our own health plan. And as far as health credentials, digital health credentials, obviously with healthcare now moving not only from a physical space to a virtual space and thinking about it but from a hybrid organization, we're looking at all kinds of different ways as far as being able to share this information with the patients. And so when you're thinking about credentials or you're thinking about your digital health record, with the 21st Century Cures Act and the information blocking rules that are coming out, we're actively working on exchanging that information with the patient, however they choose to use that information. So There's much conversation around this, and again, it's really about empowering the patient to use it however they are looking to use it. So thank you.
Thanks, Jerry. Todd?
Hi, everyone. I'm Todd Kerke. I'm the Chief Architect at ID 2020. My background is in software engineering. I've been working for 25 years in a variety of industries. In 2016, I started focusing exclusively on blockchain and distributed ledger technology, building solutions in healthcare, life sciences, automotive and mobility, manufacturing and supply chain. In common to all of these projects were the need for reliable or trusted digital identities. And so I became very involved in the W3C verifiable credentials and the decentralized identifier projects going, and integrated those into all of my projects. In 2020, I took this role at ID 2020, where I could focus exclusively on identity and decentralized identity, privacy preserving models for being able to have user-owned, user-held credentials and privacy preserving ways of sharing information. Then this last year, we became very involved in the Good Health Pass initiative, which is a coalition of over 100 organizations and companies looking for an approach to have interoperability across the myriad of solutions that are out there in the world today, to really be able to be issued a credential that you can have verified by someone who other than who issued it to you. So that's where we are.
Thank you, Todd. JP.
Everyone, I'm JP Pollack. I'm a chief architect and one of the co-founders here at the Commons Project Foundation. I'm also on the faculty at Weill Cornell Medicine and Cornell Tech, and represent the Vaccine Credential Initiative, VCI, as the co-chair of the technology working group there. So I spend most of my time helping people get access to their health information. So we at the Commons Project built Common Health, which is meant as an Android complement to what Apple is doing with Health Records and HealthKit on iOS devices. And so, work in the sort of space of vaccine credentials has been a logical extension of, helping people get information that's actually actionable. Generally speaking, health records can come and live on my phone, and I can make use of them without them having come with additional layers of trust. But when we're talking about things like immunization records, particularly COVID vaccines, we need some additional layers of trust stepped up on that. And that's how I ended up here working on this stuff.
Thank you so much. Dr. Harris?
Hey, Alice, good morning. Thanks for having me. So I'm Matthew Harris. I'm the medical director for emergency management and clinical preparedness here at Northwell Health in New York. We're a large 23 hospital-based system and have served as the vaccination hub for Long Island. My experience with health credentials has been relatively limited, I think, compared to others on this call. My particular area of interest surround the security around the credentials and their implementation in sort of the public health setting, which I think is obviously at the forefront of everyone's mind, how we leverage this technology in an equitable way to help us emerge out of the pandemic. So it's a pleasure to be here, and I hope I can make a meaningful contribution.
You already have. And last but not least, Mark.
Hi, everyone. My name is Mark Treshock. I'm IBM's global leader for blockchain solutions in healthcare and life sciences. So I work to apply blockchain and other advanced technologies to industry challenges. I spent a lot of time focusing on the pharmaceutical supply chain, so track and trace of prescription pharmaceuticals. We did work with Merck and the FDA and Walmart around that. But then most recently, I'm one of the leaders of the Excelsior Pass implementation in New York. And for those of you who aren't familiar with that, Excelsior Pass is a digital credential available to all New Yorkers in New York State for COVID vaccination and/or test results. It's based on the IBM Digital Health Pass, which is itself based on W3C and other common standards. I'm sure we'll get into that during the discussion, but this Excelsior Pass is now live in New York, and approximately 1.5 million of them have been issued to date. So this is a project that we're all very excited and very proud of. Excited to talk about it today.
Me too. And I could ask each of you about 11 follow-up questions because all of your work is so fascinating. But I thought it might make sense to start just at a high level. Health information technology from a legal perspective, from a technological perspective, from a policy perspective, has never seemed to me to be particularly partisan. Almost everyone agrees that we need more and better health information exchange, more and better interoperability, that healthcare technology should be doing a better job keeping up with advances, technological advances in other sectors. So it was interesting, at least intellectually, over the past few months to see COVID turn digital health credentials, which have been around for years, into such a hot button and even divisive issue. And I think that's probably due in large part to this concept of vaccine passports, or that phrase. But just for level setting purposes, because we're not just talking about vaccine passports, I was hoping that for the dum-dums among us like me, if someone could just define what a digital health credential is and how they are designed, how they're powered, that would be helpful, I think, from a shared vocabulary standpoint.
I can give that a go. So I think the first thing that I wanted to say was that, I noticed in some of the questions that you sent out, the term passport was used, and we really tried to stay away from calling it a passport, because we see passports as being, and when I say that, it's not just ID 2020, but in working with GHPC, we've been trying to come up with a common vocabulary. And so when we talk about passports, we think of it as a travel document issued by a government. And most of what we're talking about with credentials around immunization or tests are not issued by governments. They might be issued by health authorities who are under a government, but they're not issued by the government themselves. And then the other two terms that are used is I'll do this one first, is the term credential. And credential has a very specific meaning to technologists. It's been around for years and years. It's sort of the foundation of the public key infrastructure that we use on the internet, for secure sockets, for the HTTPS that you see. And a credential is a type of signed document, and it's a very hierarchical structure. It's referred to as a X509 standard. It's usually, where someone issues a credential to someone else, and then they can then issue a credential to someone else, and you can travel that back to the root of trust and say, I trust this because my issuer was trusted by this issuer, and so on and so forth. And then the last one that we talk about is our verifiable credentials, or credentials. And, although you mentioned that credentials have been around for years, and digital credentials have been around for years, and we throw around this W3C standard, there is a 1.0 standard out there, but there are various formats of digital credentials. There's 4 primarily that are being adopted. And so interoperability is a problem. But one of the unique characteristics of not some, but not all credentials is, rather than like a certificate where the entire body of information is signed and you have only a mechanism to share that body of information, it's an all or nothing. With a certificate, you can typically do a thing called selective disclosure, where you're asked to disclose certain fields from there, and you can prove the signatures on the individual fields. You can even collectively bring them together from a variety of credentials. And so this is very young technology. It's moving really quickly. It's been accelerated by COVID. But I think it's important to understand the differences between these various types of certificates, credentials, and then even within the credential space, there are differences. And so I'm sure the others will have more to contribute to that.
I would maybe just add one additional wrinkle, and that's how this relates to health records. So it's interesting because in New York with Excelsior Pass, this is something that the state became keenly involved in. So the Excelsior Pass, it is not a health record. It's an attestation of a health record, right? So New York State itself is attesting to the fact that an individual was fully vaccinated against COVID. And this distinction versus your CDC card, which everybody loves to make fun of, which is technically a health record with the immunization, the shots, the dates, the providers, et cetera. The distinction was very important to New York because creating an attestation of a health record had a lighter burden, regulatory burden, legal burden in their mind, right? In the mind of the state government, versus if we tried to put the entire record into the pass itself, that kicked us off in the complexity that, given the speed at which we were moving at, we didn't want to tackle.
Maybe one last bit of, or maybe not last, but one extra bit of nuance to add. A lot of the sort of definitions that you see around credentials and clinical records and passes have to do with the types of rules that maybe get applied along the way, or where you might use those. So a lot of the work that I've been doing has been focused on sort of the upstream generation of these records from health systems, from states, from pharmacies. And what we're really talking about is just clinical data that have been signed. So maybe a credential at most, a certificate, however you want to define it, but really it's a copy of your health record that comes with some assurance that it hasn't been tampered with and that it was generated by a trustworthy entity. But to take that the next step further and use that to maybe walk into a concert venue or to get on a flight, that's when we start to get into the territory of what a lot of people consider to be the health passes. And I think a lot of that distinction has to do with some set of rules or logic being applied, or maybe some privacy preserving techniques being applied to turn that into something that is akin to a better version of your CDC card, into something that you actually want to sort of hold up and let get you access to something. And so some of the the types of rules and techniques that get applied. So it could be that a specific venue or a country has a set of rules that allow you to get in, right? And so you could have a pass that's created specifically to get on your United flight to Iceland. You could have a pass that grants you access to all sorts of venues in New York State, because the state and the venues have agreed that some period of time after your last immunization, or some period of time within certain test results, you're considered to be safe to enter. And so you get a pass for those sorts of purposes. The privacy preservation is the last sort of piece that I think is pretty important. And the Good Health Pass folks have done a lot of work to help define some of this. And I think there's some documentation that will be forthcoming pretty soon from them, which will go into a lot of detail about this. But the idea that I don't necessarily have to show someone the entirety of my immunization record, or maybe I don't even have to divulge if I was immunized or if I have just taken a negative test, could be enough to generate one of these passes. So, for example, Iceland might tell me that I need to either be vaccinated within a certain period of time, or I need a negative PCR test result. If I can generate a pass that says I'm cleared to enter Iceland, that probably has some benefits for me over, for example, sharing that I was vaccinated at the beginning of January, which would convey certain things about maybe my health status or my occupation.
I might just add that I think as we think about how to translate this to the consumption of the general public, that the general public is worried about access, right? They're worried about how this is applied for, as I think JP mentioned, the day-to-day things, right? I think that we're speaking at a higher IT level here, but for the general public, they want to know that their information is secure, and they want this translated to the point of how is this going to impact their lives, right? If I'm going to download this and take the time to upload whatever bits and pieces of medical information are going to define me and my place in society and my ability to access certain venues, airports, what have you, I think it's going to be crucial to make sure we have not just a common vernacular amongst the echelon of folks who design these tools, right? But also how do we translate that to the general public? Because that's probably where this issue is going to be hottest.
I think that's very well said, and is sort of gets at what I was going to ask next, which is, when COVID broke out and we started to contact trace or attempt to contact trace, there wasn't particularly successful uptake in the US of digital contact tracing tools. And I think that's, to exactly to your point, Matt, about trust in the system. Where's that data going? Is it going to stay private? A little bit of sort of overall big brother fear. And I wonder, I'm grateful to hear and know enough about the Good Health Pass initiative to know how central privacy has been in the rollout or design of the program. But it sounds like, Mark, that the Excelsior initiative or tool, pass, whatever you want to call it, and now I'm going to get self-conscious about my vernacular, but it does sound like there's been successful uptake. And I just wonder if you see differences in the contact tracing tools with the health credential or pass tools, and if there's been sort of a public communication or education around that has successfully alleviated some of the concerns.
Yeah, so no, thank you for that. There has been successful uptake of this, and we continue the rate of pass issuance. The rate itself is increasing, and in part that's due to the state's efforts to communicate the program, which could always be better, but they certainly are better than we've seen in the past. But also, I think the difference between this and something like contact tracing, it has almost a negative connotation. If I'm from the perspective of an individual, have I been exposed? Do I want to know? Do I want to share that? How will you judge me? Will society judge me? Whereas this is something that's almost completely affirmative, meaning you don't get an Excelsior pass if you have a positive test, right? There isn't one that says you haven't been vaccinated. So you could only, by getting these passes, you could only do positive things with them. And in this case, positive things means sort of returning to life and society. And I think that's contributed to this. But there's a long way to go, because you're right, in Florida, where I live, they've outlawed these, quite literally. They've literally outlawed them, which is amazing to me. So yeah, it's very, perception is very different across the country.
I wonder if that's such a huge difference between New York and Florida. Again, it seems that we're talking about the same thing, the same technology, the same positive benefits. And I wonder if any of the rest of you have thoughts as to how to do the rollout of these tools that in theory are only going to make people's individual lives better and the world economy better if we can move around. Are there, I mean, this is obviously a huge question that many, many people are spending tons of time on, but do you see there particular avenues or better ways to talk about these technologies? I mean, even just listening to you all talk about your work, there were half of the words that I didn't quite understand, even though I spend most of my time working on these types of issues. So I wonder if it's a translation of the technology to the benefits that they provide. And I know all of you in some way are involved with efforts to roll these tools out to the public to do good. Any thoughts on how we talk about them that might make them seem more appealing or even just less daunting and scary, such that someone would just say, I don't want that, or I don't want to give my information to that, or I just don't even want to know anything more about it?
You know, it seems like, from my perspective, a lot of the concerns are around inclusion and, you know, creating a two-tiered society, those that have passes and those that don't. And that's a totally valid concern. I think that we have been talking a lot about privacy. We've been talking about, you know, not revealing more information than you need to. But I think that there are other ethical concerns that really need to be discussed. And if we start, you know, trying to promote the passes without really having those conversations. And the other thing is that we look to technology, you know, as technologists, we always want to solve the problem. We're looking to technology to solve some of these inclusion problems and some of these privacy problems. But I think that there's some of these things can only be addressed with regulation. You know, when is it appropriate to use a pass? What type of passes are appropriate to use? You know, right now we're talking about COVID and we're really concerned, but once we build this infrastructure, once we get the trust framework out there, these could be used for anything. and the technology can't control what it's being used for. And so I think a good way to address the concerns is by having the discussions about, both the good and the bad, and looking to legislators for some sort of protections, maybe not the approach they did in Florida where they just say nothing, because there are appropriate uses, but there are also inappropriate uses.
I think there's two points that come to mind. One is that, going back to your original question about contact tracing, is that these are, as a non-technologist, these are a push. I am opting to provide this piece of information to the system, right? In this case, it's a test result or a vaccination result because it's presumptively something I want from it, some benefit that I gain from this, whatever those benefits are. Contact tracing is a pull. Who were you exposed to? What have you done? I know you were in this school with this child in this classroom yesterday. You're sort of giving up. I can understand why some people might think they're giving up some degree of privacy. Whereas if I am opting in, it's my right to push into this. I do think, though, that and relating back to your prior question about the political undertones here, that there's a greater degree of distrust in society than I thought there was ever could be existed, frankly. There are these blurry lines of, if you're in a public, let's say you're in a public, I have young children, I go to a public park, will there come a point where someone says, you have to be vaccinated to come into a park, pull out your card, show me your app, is that enforceable, right? Whereas if you look at the Israeli experience, they've, for many years, have had 1,000 different reasons why you can't enter into a mall without having a brief stop. But I mean, the Israeli experience, from what I understand, using their pass, has been net positive, right? It's been, it's been an added layer of protection that's a minimal inconvenience. But again, it's a carrot and a stick. If you don't have to put it in, but if you want to go here, this is what you have to do. And I support that gesture personally.
I would also build on that, Dr. Harris. As we're looking at all of these topics, interoperability rules and exchange of information in healthcare has been a discussion topic about sharing this information with the patients. And so when you look at vaccines and the information that we're trying to share with our patients, it falls along the same lines, but suddenly this one became a hot topic. And I think it has a lot more to do with answering the questions on why certain populations haven't received the vaccine yet, and all of a sudden creating an exclusion around that vaccine. So I think we need to start a little bit farther back as far as, as a society and as a population, to Dr. Harris's point about, does everyone have accessibility to the vaccines? And are there questions about receiving the vaccines that some people are showing some hesitancies, and how do we get there? So that way it becomes a conversation about sharing the information. So that way you can be in an area that, it has the population that it feels comfortable sharing this information.
From an operational standpoint, I think it was JP who made the point that what we're really talking about is credentialing health records, or attesting to the fact that what we're seeing in these tools comes from an individual's health record. And then that, of course, just makes me think about all the poor providers who have to figure out some way to actually operationalize that. And I can only imagine the sort of logistical and workflow issues. I spend a lot of time talking about the privacy implications of pushing data from the healthcare system into individuals' hands because of the loss of HIPAA protections. But I've also heard that on the provider side, there are a number of challenges with just sort of how to get the right information to the right people. How do you verify identity? Who is in charge of doing that in these otherwise packed schedules? Jerry and Dr. Harris, I wonder if you could just speak to a little bit about how this works in practice, whether we're talking about the COVID vaccination context or even just information to a wellness app that an individual might have on their phones. What are some of the challenges or positives that you're seeing?
Jerry, would like to begin.
Yeah, so it's a complicated nut to crack, I would say. So when you think about all of the way that the landscape is changing in healthcare is quite tremendous overall. And to actually create a longitudinal patient record for your patients with all of the different standards around the EMR and also structured data to pull this information together is quite a bit of a challenge, something that I think most healthcare institutions are facing. Then to turn around and expose that not only to other healthcare organizations or to national HIEs, when the standards in place are not standardized, it becomes even more complicated. And then on top of that, now exposing that information to the patients poses another logistical issue as far as being able to identify that patient, as well as being able to identify their access to their information. And to do this at a mass scale is challenging in itself. When we think about patient identification, I am able to identify my patients. I'm able to identify my patients at the state level as well. But when you're thinking about it from a national perspective, especially when you added vaccinations in the middle of all of this as well, I can again see what I've vaccinated on our patients. I exchange that information with our state, but to think that some of our patients went and got a vaccine in another state while they were visiting a family member, and now trying to collect that information so that I have a complete health record also adds some complexity. So it is about a lot of understanding as far as standardization is concerned, as well as being able to identify the patient and ensuring the credibility of that, and then exchanging the information is complicated.
Yeah, Jerry, you touched upon a lot of the same points that we struggled with in our vaccination rollout. So we are in New York, we have lots of snowbirds who are down in Florida, in Mark's neck of the woods, and we came back up here and said, I want a second dose. And in addition to some of the regulatory issues of whether it was clear or not whether we could vaccinate someone who was maybe not a New Yorker, but the full, 6 months in a day in Florida. But these are issues we still struggle with. We struggle with folks, and I'm a proud non-card carrying Excelsior Pass person here. But we struggle with folks who've gotten a first dose at a chain, a national chain pharmacy, and then come to a mass vaccination site in New York or to a health system vaccination site, and we can't match up their records, right? Because, as a pediatrician, in my prior life, I can go into NICIS, our state immunization record, and look up and see where someone's been vaccinated. But getting access to a state immunization record is really cumbersome, and having to do this in large numbers amongst thousands of staff members across hundreds of vaccination sites in New York State would have been prohibitive at best. So not only is it a problem of getting information between states, it's getting personnel access to the type of information they need, and doing so that in a way that maintains privacy compliance has certainly been a struggle I think all of us have faced.
And have as a recovering lawyer, I always think about the new regulations that are in play here. So I just wonder, Jerry, you mentioned them earlier, but the ONC, CMS interoperability and information blocking rules that are just part of this overall push to get information into the hands of individuals. Again, admirable and wonderful, but I can imagine that adds another layer of sort of urgency or volume into those data flows.
Yeah, it does add that urgency. So not only have the rules have taken place, but also, again, moving to this virtual healthcare model, not only from a physical, but a virtual healthcare model, and the mobility of our patients creates this exchange of data across multiple organizations, multiple states, multiple institutions that add the volume is definitely exponentially growing.
Well, good luck with that. I was going to ask, we could spend an entire webinar, a 5-hour webinar, talking about the digital divide and digital literacy gaps and technology access. But for those of you who are part of these initiatives that are developing these amazing tools that can do so many wonderful things, of course, there are privacy concerns, and privacy again tends to cut across race, class, geographies, socioeconomic status on at least some fronts. But if you don't have access to a smartphone or a computer or the knowledge to know what these tools are and why you would even need or want them, they obviously fall flat. I can only imagine that this has been a huge part of the work that those of you who are on the technology side have done. So, again, understanding that that's a huge question and a huge topic, I would just be interested to hear about how some of these access or equity issues are coming into play in your work.
Yeah, I'll start. So in VCI, the work that we've done has focused on a few different ways of getting people access to their signed health records. So one is using all of the same APIs that have been enabled by the ONC regulation, and that's of course great for people with smartphones and for people who visit institutions that are already connected and have APIs, right? The next is basically a way that you can just download this file to your smartphone and use it in the app of your choice, which takes a nice, sort of positive step in that it doesn't require APIs, it doesn't require integration. So that sort of, expands the breadth of different apps that might be able to connect up. It expands the breadth of, the types of institutions that can offer up these services to their smartphones, but we're still sort of stuck in this smartphone world. So whether, an institution who's issuing chooses one of those, that's sort of up to them. But the requirement for participation is that they issue the credential in at least as a QR code on a document that can be printed. And this is, so we have one of these technical methods, but then also a means where you can simply go and print out your QR code. Importantly, it's not just something that I can log into my computer and print out, but the various EMR vendors and the pharmacies are working on tools. I believe Epic has talked about theirs, in which a doctor would be able to log in, or an admin would be able to log in and select the patient and be able to print out the record directly from the clinician-facing portal as well. We have hopes that some of the pharmacies that are participating are going to be able to take folks, maybe not completely off the street, but someone with whom they have a relationship and is able to sort of show ID and be able to print out one of these documents on their behalf. So those are sort of the steps that we're taking to provide access, getting to folks where you don't live within walking distance of pharmacies, you don't have direct relationships with providers. That's going to require some state level effort, and we're not quite at that point just yet.
And I'll just add in for the perspective of New York, we spend a lot of time working on the broad issue of accessibility and did a lot of work. And in the end, it got us, nothing will completely close the gap, but we did a fair amount around that. So in stepping back and thinking about the pass itself, so first of all, Excelsior Pass right now is available in, I think, 9 languages. So this was very important for the state that it reflect the diversity of New York. So the pass, the FAQs about the pass, the instructions, that's enabled in an extraordinary number of languages. So Bengali and Yiddish, 2 things I never thought I'd say in the same sentence, for example, are supported in this platform. So that's one piece. The other piece too is that, like you mentioned, the credential, it could exist on a smartphone or it could be printed out, right? It very much exists like an airline boarding pass, or you could take a picture of it and store it in your wallet. So we're trying to make it accessible in that way. And from the perspective when it is on a smartphone, under New York's direction and really leadership, the apps in which the credential sits, we've gone through measures to make the accessibility of those apps, everything to make them as accessible as possible for people who may have visual impairments, for example, to make using a visual credential as easy as possible for people who perhaps can't rely completely upon their sight. And then lastly, I'll say that the way the system is designed, without going into too much detail around this, it's designed such that someone could come, if you don't have a computer at home or a smartphone, you could go into a public library, go through the process of getting the pass, print it out, and close that browser window, and have absolute confidence that your information is not persistent. Right, so it's a stateless system. It exists completely on the edge, so you don't have to create a username or password to access it. So that's another way. And New York is in the process of setting up print stations, you could think about it. So people could come in and print these things, or as public libraries open, suggesting or directing people that they go there and get the credential and print it. So certainly it's not a complete answer, but it got us a little ways down that path.
A couple of questions have come in about what's the future of a vaccine, again, passport, not the right phrase, but what's the future of this sort of Excelsior type pass if so many states have opposed it? And I wonder, Todd, is there a domestic analogy to the Good Health Pass? I assume that there are. I assume that in New York is working with other states. I'm sure there are plenty of states who are trying to work together, even if there are some who are having a little bit of a temper tantrum and saying they'll do nothing. But are there efforts out there that I just don't know about that are multi-state, cross-state efforts to do something like the Excelsior Pass, something like the Good Health Pass in the US?
Well, that's a really good question. I think some of that goes back to some of the ethical issues in regulation around use that I brought up earlier. But one of the things that we did in the Good Health Pass initiative is we were focusing exclusively on global travel. And we did that mainly because the impetus of the project was for the airlines and to get people be able to cross borders again, but also when you're in a global travel scenario, you don't have the same civil liberties that you do when you're going to a yoga studio or something else. And so it afforded us a couple of different things. One being that most people who are traveling globally already have a passport, and so the identity and the identity binding was easy. And but when you're talking about other use cases and other scenarios where this could be used, I don't know of any initiatives that are going on state by state. But as far as other use cases, certainly visiting an elder care facility, a hospital, in some cases, workplaces may need to be able to check credentials. But I think that the short answer is that we really aren't looking at that right now.
If I could quickly, this is one of the ways that we're trying to depolarize this debate. If we step back and think about where else in society we already ask people to prove they've been vaccinated, it's surprising. So schools, secondary schools require vaccinations. Setting aside COVID vaccinations for a second, there's a tendency towards requiring flu shots. Various states, Massachusetts, for example, will mandate flu shots for K through 12. Starting in the fall. Then universities, for young adults going to university, require MMR. Some of them require meningitis. So there's a precedent that people don't necessarily think about of vaccinations being required in other conjugate settings. So now you asked, what's the future of Excelsior Pass or things like it? That is clearly one setting, because universities across the country and secondary schools are asking us and talking to others about this, right? So universities in New York are saying, how can, some of them are going to require COVID vaccination. So how can we ingest COVID vaccinate or the Excelsior Pass to allow our students and employees to prove this? And can we get the state to just issue an Excelsior Student Pass, which is a combo pass of COVID, MMR, and meningitis, all wrapped together in one attestation, right? So I think that's the future. It's making this a process digitization, a question of process digitization and convenience, depolarizing it, depoliticizing it from terms like passport and border and things like that, to just make it a streamlining of services.
Mark, I think one of the questions I have about that is how universities maintain, for lack of a better term, to police that information, right? Is there a technology solution? Because we've talked about this at Northwell and in other contexts about even if there was an appetite, and again, schools are a great example, but even if there was a more global appetite for using this as a passport, port of entrance, what have you, it's still the question of the person at the door checking it, right? Unless there's an IT solution to that, right? Otherwise, this is a wonderful patient-friendly way to replace faxing, emailing your vaccine records to SUNY Albany, right? I think, and I think that's where, from a public health perspective, this is, I think, the big bone of contention and maybe a big difference between, New York and Florida. How do we do this? How do we maintain this? And how do we sell this to the public as something that, again, we're kindly asking and sort of telling you to participate in, right? This is the carrot and the stick. We want your kids back in school, but you need to be protected to go back to school. And we've done this before with measles. We've done this with flu and other contexts. But it's a carrot and a stick, right? It's also a subtle way of saying you need to do this to get your kids back to school.
Right. Right. And that's absolutely. Oh, please go.
No, go ahead. One point that I would make, and this goes back to the technology, and I'm familiar with the work that JP is doing. I'm familiar with Mark's work, and in all cases, what we're looking at is a method where these signatures can be proven without a phone home. So in other words, we're not calling back to the issuer and saying, Todd showed up, he showed me this pass. So that goes a long way in circumventing the surveillance economy that we know everywhere everybody goes. So decentralizing that, where you've got it on your handset, and the signatures can be verified by checking with a trust registry where the list of trusted signatures or the keys for them are there, and it really minimizes the risk and helps with the privacy. So that's a big component. The other component is what data is shared. And I saw something come across in the chat earlier where someone was talking about big tech collecting data. In these cases, it's especially with JP, I look to you to say more about this, because with what they're doing, they're not sharing the health data, they're sharing an attestation that you had a vaccination. And that's very different than sharing your immunization record itself. And so consequently, it's not that the verifier who checks it at the university now has a copy of your immunization record. They just have a attestation that some organization asserted that you did have an immunization. Now, true that true false can be a piece of data and it will be used. And so, we need to consider that, but there is a lot of work going into how can we, from a technology standpoint, protect the information and protect the holder of the information.
Yeah, and I think that's one of the interesting considerations in this, and it does speak to how this evolves into the future, right? Today, we're in a scenario where maybe less so in the US, but in other countries, we're seeing people have to show vaccination status to get access to day-to-day type services. In the US, we'll probably end up somewhere in the middle. We're certainly going to have lots of schools that require immunizations for this fall. We're seeing, getting on flights to Hawaii, likely in the near future, to lots of international destinations are going to require, or at least be able to let you prove vaccination status as a way to get around certain other quarantines, things like that. And then we will undoubtedly have some of the stuff in the middle, like concerts and certain large business venues, conferences, things along those lines. And how we manage the aspects of traceability and tracking, like we're just talking about with disclosure of my health information versus other kinds of information, I think will likely evolve along with these use cases as well. There are entities like the student health organization at my college that maybe I don't care if they have access to my immunization record, because they have access to lots of health information and they know how to deal with that. My airline, I might feel less confident about turning over copies of my health records too. And so I think we'll see evolution in both the trajectory of where we're using these types of technologies, as well as the amount that needs to be disclosed to different parties, and building technologies that are flexible in this way to support these different kinds of use cases while offering people choice and privacy and flexibility is definitely key at this stage.
Yeah, I think JP, one of the things you brought up a conversation from this weekend with some other folks around here that I think the general public, to your point, wants to know that their information is safe, right? That we don't want the use of this type of information to be a barrier to further vaccination, right? So I was thinking about how at my kid's soccer game this weekend, my wife and I were masked, right? We're fully vaccinated, and despite New York loosening up its laws. But so the reason I bring that up is that people know that I'm still probably it's unlikely that people who are unvaccinated, now that laws have loosened up, are still masking out on the soccer field, right? And similarly, the people who we want who've proactively sought vaccination, I imagine, are going to probably feel a bit more free to say, great, I'll get a vaccine. Again, not to use the term, but the vaccine passport. I do think it's so crucial, however, for those who are vaccine hesitant out there to know exactly this type of information, for us to translate this down to their level to say, this will not be used to track you. This will not be used to follow you from door to door. This is meant to facilitate your education, your travel, and so forth. We don't want this to be a barrier.
Such excellent points. And I wonder, outside the education, schooling context and travel context, do you hope, worry, are there other scenarios in which these credentials may be used in a way that is beneficial and doesn't further scare people, as Dr. Harris was just saying? I wonder if, I don't think we'd ever heard or thought before that concerts or public parks or places like that would ever require proof of anything. I wonder, maybe from a business standpoint, it's great if they do because we've got the tools here, but are there other scenarios or contexts in which the technology that you all have developed and are using is a game changer in a good way for people beyond but beyond the school vaccination or international travel context?
I think you can make the argument. Oh, sorry. Go
ahead, JP. Go ahead. I've been talking too much.
Yeah, I think one of the arguments that a lot of us have tried to make early on is that we're not talking about taking existing services or taking existing events that would be happening and making them inaccessible to people. The idea is that with proof of vaccination, things like cruises, which were have been cut off for months and months and months, are now going to be permitted starting, again, literally any day now for, ships that are filled with, I think, 98% vaccinated passengers and crew, right? So concerts, large conferences like the ones that are starting back up in the next couple of months here, we would not have held these conferences prior to the advent of being able to prove immunization status and negative test status. So I think there's some framing along those lines that can be helpful. Personally, I've been somewhat of an advocate for sort of sticking to mostly the tried and true, well-proven use cases for acquiring vaccination. But I do think that that when events and venues and services start to fall into this category of would otherwise not be possible and now could be, I think that's a pretty good place to start to conceptualize lines that could be drawn.
What I was going to bring up is that the technology that we're talking about, the underlying technology, has a variety of uses. And so when we're talking about vaccine passports, it's really being accelerated by COVID. The whole some of the conversations that have gone on within GHPC have done a year or more's work in just 6 weeks because people are forced to get together and start having these conversations. That said, some of the other use cases, this is an ideal for education credentials, to really be able to verify, what college you went to, what degree you had, what classes you took. It's great for prescriptions. It's great for proof of insurance. And so, we should be looking at the technology more broadly than just from a healthcare and immunizations perspective. And I think that once we start using those other use cases, and really we get the adoption, the concerns, the issues sorted out, and this becomes kind of more mainstream, then it really becomes easier to look at other scenarios where you might want to reveal some some of your personal health information in inappropriate scenarios, because you have that level of trust. You know, oh, this is just like what I use to prove my college degree when I got my job, or this is what I'm using to prove my insurance when I'm renting a car.
I'll add just in a very quickly that I agree with everything that was said. I would say that one of the things we're exploring is how to take the credential, let's say a vaccine credential, and have it do more. Right now, it's basically inert, right? You get it and it exists, and that's powerful. But the credential could do more for you. So for example, we could put into a health pass. We don't today, so just to be very clear. We could put in what kind of vaccine you've had. We could include the lot number of the doses. We could include the ability to send messages to that pass holder in their wallet to say, for example, you know, this vaccine batch you may have read something about this vaccine causing people to get blood clots, right? Here's what you need to know as a recipient of the vaccine. And if you experience any of these symptoms, this is what you should do. We could create ways to make the credential, again, people opt in, bi-directional. So 2 hours after people receive their final dose of Moderna vaccine, send them a questionnaire to poll how they're doing, tell them what to expect in the side effects so that they don't worry, tell them what to do if they experience something else, right? These credentials, this is really for us the start. We see this as the start of something, at the end of something. And of course, everything I've described brings with it other implications that need to be addressed, certainly around privacy and how that data will be used. But the potential of this is extraordinary, to create a bidirectional link with people at a mass scale that connects the very specific medicine they took to a very specific individual, potentially across the country or across the world. The implications of that are profound.
I have chills. I'm so excited. I could listen to you all talk for another 12 hours. Unfortunately, we're out of time. I can see, because the Q&A box just blew up, that all of our attendees also wish we had much more time with you. And apologies to all of you who are on who didn't get a chance to get the question asked. We will combine them and make sure that they're circulated and do our best to get back to you. But I'm just very grateful. Again, this is such a timely topic. It's always nice when the sort of nerdy interests of the few become relevant and exciting to the many. And there are not very many silver linings of COVID, but I think these sorts of discussions and these sorts of, as you said, rapid scale advancements are a good thing that's come out of this. And so again, thank you to each of you for being here. Thank you to all of you who joined this panel. A recording will be available up on the EHI website, and feel free to be in touch if there's anything else we can do for you attendees. Thank you all so much, and have a good afternoon.
Thank you.